Ultimate Health on Joy 99.7 FM with me, Naughty by Nature. Righty. We've been talking about the range of interventions for treatment and management of breast cancer.
You know it's another OPK classic.
We keep emphasizing that early detection. Then there's a lot that can be done. Sadly, every year, 4,000 plus women, Ghanaian women, are diagnosed with breast cancer. Sadly, again, tragically, we lose about 2,000 plus of those women annually. So we've been doing this focus. We're now looking at surgery or surgical interventions when it comes to breast cancer. In the preceding weeks, we've looked at chemotherapy. Last week, we took a look at radiotherapy. And today I have Dr. Charles Ansalabi, general surgeon with the AIMA Hospital, with me in the studio to take a look at surgical interventions. Dr. Labi, you're welcome.
Thank you.
Right. We've been doing quite a lot of education. There's still a lot of misinformation. There's a lot of anxiety. There's a lot of fear. And when it comes to surgical interventions, there's a lot of fear associated with that, right?
I agree.
Relatively more than when we hear about the chemo and the radio. I don't know why. Maybe you'll explain. But you're welcome once again this Sunday.
Thank you once again.
Right. So surgical interventions or surgery is a key component of breast cancer management. Am I right?
Yes.
Okay.
That's very true.
Right. I read that in about 40 to 60% of the cases, you would be looking at surgical interventions, maybe even higher.
Yes.
Right. And most people don't want to hear this. And when they hear surgery with regard to breast cancer, their minds immediately go to the removal of the breasts. Let's give us a general introduction or overview when it comes to surgical interventions with breast cancer.
So, breast cancer management in the 1960s.
Right.
Surgical intervention. The main surgical procedure that was done at that time was mastectomy. That was in the 1930s. Mastectomy. That was removal of the entire breast. And it wasn't just the breast. It included the muscles of the chest.
All right.
The pectoralis major.
Okay.
Right. So that was what was being practiced in the 1930s.
Right.
But with the introduction of chemotherapy, radiotherapy, now the morbidity, because in the olden days, once you remove the muscles, it means that you can't make use of that muscle very well. Okay. It means your joint to be affected. So the morbidity was high. But when they introduced chemotherapy and radiotherapy, and then with newer interventions in terms of surgery, now they don't remove the entire muscle. That's the pectoralis major.
Right.
So now they introduced other surgical procedures.
Okay.
So with the introduction of other surgical procedures, the morbidity decreased. So in the olden days, people going for surgeries were scared because of anesthetic complications and all that, not just related to breast cancer surgeries, but cesarean sections and all that. So immediately you tell somebody that, oh, we need to operate on you. The person is scared because people were in the olden days that once you go and do surgery, you might not wake up from anesthesia. But these days, everything has changed.
Right.
Science has evolved.
Okay.
New treatment methods. And then the fact that with anesthesia, complications are now limited. In the olden days, we talked about quadrantectomy, where you remove the whole quadrant. I mean, we have 4 quadrants.
Right.
But these days, we talk about wide local excision, where you can conserve your breast. So in that case, you are just going to remove the tumor and then a margin of healthy tissue. And then following that, you are going to do radiotherapy and all that. So now people can conserve their breast.
You're actually in the business of protecting, conserving the breast and breast tissue. You're not just going in there to do something drastic and should I say kind of a broad stroke intervention as you used to do in the past. Okay, so you have more options and you're more minded towards minimizing collateral damage. Right,
Exactly,
which is what you're suggesting when you use the word morbidity,
Sure.
right? Okay, negative outcomes or challenges following surgery,
Yes.
right? You're saying that is, should I say, significantly reduced now,
Yes.
with the methods and the strategies and the technologies available, right?
Exactly.
And then instead of going in there and taking off the whole breast muscle, chest muscle, and all that, now you can look at targeted smaller areas and you may be able to conserve the breast as it is and target the lump itself. Okay, folks, if you just joined us, it's 15 minutes past the hour of 2 on Joy 99.7 FM. Program is Ultimate Health with me, Norte by Nature. I'm with the surgeon today. We're looking at surgical interventions with regard to breast cancer, right? And we're going to take it step by step and get a certain understanding. What we aim to do is to inform and transform your understanding, your perceptions, and even your choices when it comes to breast cancer management. You can share your concerns with us. WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. And shortly, I will activate the phone line so you can ask the questions yourself or, share your experiences, anxieties, fears, and even some of the misinformation that you may be in possession of. Right. So, Doc, that gives us a kind of an overview. For many people, though we've done the stepwise thing and we left you till last, they want to know because they get the sense that breast cancer surgery is the first step. Surgery is what you hear first. Is there any sequential arrangement or is it a unique breast by breast, case by case basis?
Right. So the management of breast cancer, it's multidisciplinary.
Right.
So it's not just the surgeon who manages breast cancer. So you include the oncologist and then the radiotherapist.
The radiotherapist.
Yeah. So I think the radiotherapist is almost performing the same thing as the oncologist.
Okay.
Right. So, and then apart from that too, you need a pharmacist, you need a psychologist, and everybody.
Okay.
So instead of operating on an individual with a breast tumor, nowadays it's not always surgery.
Okay.
There are other treatment options.
Right.
So we start with, first of all, we start from establishing the diagnosis, which you need surgery. That's the biopsy, because you need to take a tissue and then send it to the lab and then establish the diagnosis that indeed it's breast cancer. If you don't do that, you cannot say that it's breast cancer. So once you get a report, now there will be a meeting. That's the multidisciplinary team.
Okay.
So now the multidisciplinary team is going to find out the clinical findings, if the tumor was smaller or it was bigger.
Right.
So assuming this tumor it's more than 4 cm,
right,
then you consider breast conservation surgery. If it's less than 4 cm, then we look at the breast conservation surgery.
The smaller it is, the more likely it is that you'll be able to undertake surgery that seeks to protect and conserve the breast.
Exactly.
Okay.
And then we look at whether the tumor is operable.
Okay.
So if the tumor is going to be operable, you are looking at the location and then the size at the same time.
Okay.
If the tumor is around the nipple, it means that it will be difficult to close your incision once you remove the...
Once you cut around the nipple.
Yes. So instead of going for breast conservation surgery, it's not going to be easy because if you are removing the tumor, you are going to include the nipple areola complex, which means that you will not be able to conserve your breast because now you have to remove the nipple, the areola, and then the tumor with the breast tissue, so the nipple thing will be gone. So it's not
okay. Let me slow you down a bit for the benefit of my listeners. Okay, inoperable. You're saying that based on the clinical findings and presentation, what you see when you go in there to look, and then when you take a biopsy, okay, you confirm it is breast cancer. Now, you as a surgeon are describing a situation where looking at the tumor and based on the clinical presentation and evidence, you're suggesting to us that some tumors may not be operable, may not be, should I say, conducive for surgical intervention. Is that what you're saying?
So, exactly. Right. Some tumors may not be. So, we classify the breast cancer progression. Mm-hmm. So we have early disease.
Okay.
And then we have locally advanced.
Okay.
And then we have metastatic.
Right.
So if it's locally...
Metastatic meaning it has spread.
It's spread.
Beyond the breast.
Exactly.
Okay.
So surgical intervention becomes necessary when it's just limited to the breast.
Okay.
Now, with the surgical intervention, now you have two options. Either you are conserving the breast, or you are removing the entire breast.
Okay.
If the disease has spread beyond the breast, it's gone to the lungs, it's gone to the liver.
Right.
Now you don't do surgery again.
Okay. Right. Because surgery aims to remove the tumor.
Yes.
So the location of the tumor, the size of the tumor, renders it what should I say, amenable to surgery or not.
Yes.
Okay. And then if these tumor cells have spread beyond the breast, then there's nothing really you will be doing
again
or achieving by removing a tumor located in the breast.
Yes.
So what you're saying is that with such a case, after review, the person may be told that, well, we're actually not going to undertake surgery. Is that right?
Yes, but even though we are not going to undertake surgery for that patient, we manage the symptoms.
Okay.
Apart from the patient going for chemotherapy, we manage the symptoms.
Right.
Because sometimes when it gets to the pleura, we need to go and drain the pleural fluid.
I would love it, Doc, if you could just, when you use these terms, if you can break them down. Otherwise, my listeners will break you down. Right? So you're describing and naming parts of the breast, right? Or parts of the anatomy, right? Of the breast. So when you say pleura, what does it mean?
So pleura is the covering of the lung. The lungs.
Okay.
What is covering it? So sometimes some of the tumor cells can get to the lung covering.
Okay.
Yes.
Right.
So so it's management of symptoms.
Okay.
Surgically.
So you may go in surgically to reduce some of the symptoms.
Sure.
Okay.
But you are not removing the tumor.
You're not removing the cancerous
breast
tumor.
Yes, you are not removing the cancerous tumor.
Okay.
You are draining the fluid so that the patient will be able to breathe.
Okay. Right. Okay. Earlier on, you also said something. I just wanted to understand. I know when you take a specimen of breast tissue or suspected cancerous tissue for examination by the pathologist, the histopathologist, right?
Pathologist.
Right, they do that. You said something which suggested that even biopsy can be considered surgery. Oh?
Yes.
Okay.
Yeah. Because, surgical intervention, you are cutting into a tissue.
Okay.
Yes.
Right. So when you do a biopsy, it does involve some cutting.
Exactly.
Right. So that is done by a surgeon.
A surgeon.
Okay. All right, folks, 23 minutes past the hour of 2. I'm trying to get Doc to slow down and break down some of the terms so that you can also appreciate what we're talking about and then relate them to your questions, your experiences, and maybe your fears and anxieties. WhatsApp is 055 1111 997. We're live on Facebook and YouTube. The program, as always on a Sunday afternoon on Joy, is Ultimate Health, your ultimate guide to healthy living. I'm talking with Dr. Charles Ansah Larbi. He's a general surgeon, and we're looking at the range of surgical options for the management of breast cancer. If you have any questions, concerns, WhatsApp again is 055 11 11 997. Okay, so a range of decisions being taken, right? And you're helping us with the understanding of some of the fundamental steps. But as yet, as we've talked, apart from the reference to the biopsy, no surgery or no significant surgery has come up yet.
No,
okay.
It's not significant.
We haven't cut anything yet, folks.
It's even a bedside procedure.
Right. So these are things which are really, they constitute part of the investigations, the assessments, building up to what you will do surgically.
Yes.
Right. Okie dokie. There was another one I was going to ask. I asked if surgery would come first, and we've explained that many people understand that even if they have surgery, of course, they will also have the other arms of intervention, chemo or radio. Is that right?
Yes.
Why is that so?
So we always look at the histopathology after surgery.
Mm-hmm.
So we are looking at the pathological analysis.
Okay.
If after surgery, the tumor that's removed, whether mastectomy,
okay,
or wide local excision, that's the breast conservation surgery.
Okay.
Yeah. You send the sample after every surgery. Once you take out a body part, a lump, you send it to the pathologist.
Okay.
So the pathologist will give you another report, which is different from the biopsy that you used to establish your diagnosis. Now, so once the pathologist gives you that report, in the report, there are things we look out for. We are looking at the number of lymph nodes because we know that the breast, it spreads to the axillary lymph nodes. So we are looking at the number of lymph nodes.
Okay.
We are looking at the tumor margin. And then we are looking at the hormone receptor status.
Okay.
And then there is something we call Ki67. So with the hormone receptor status, that's the estrogen receptor or progesterone receptor.
Right.
So
some of the cancer cells are responsive or reactive to certain hormones.
They are sensitive too.
Sensitive. So you want to make sure you have this type or that type of hormone reactivity with regard to the person or the patient you are looking at.
Yes.
Okay. So you would undertake that kind of analysis.
Yes.
Right. Okay.
So if it's a triple negative, then it means that patients will benefit from what we call adjuvant chemotherapy.
Okay.
Because it's triple negative. It's not going to respond to any estrogen or progesterone drug.
Right.
So in that case, we need to offer chemotherapy.
Okay. Right.
Yes. And
Doc, just to help my listeners, this essentially also goes to the point we've been making all along in this series that your breast cancer is different from somebody else's breast cancer.
Yes.
Even if you may have familial or family history, right?
Yeah.
These determinations and investigations need to be conducted so we see what type of tumor you have and so on and so forth to be able to respond to it appropriately.
Yes.
Okay. So if it has these hormone receptors and this and that and will not therefore respond to hormonal therapy or this and that, then you know and you are able to eliminate, should I say, unhelpful or redundant interventions. You're not going to do something which is not going to address the problem you've seen and identified.
Exactly.
Okay, right, understood. Right.
So we have mastectomy and then we have wide local excision. That's the breast conservation surgery.
Okay.
So with the breast conservation surgery, immediately you are done with breast conservation surgery. Then the next thing will be radiotherapy, because it's assumed that surgery will not be able to remove microscopic tumor cells.
Okay.
Tumor cells you don't see during your surgery.
Right.
So it means that you need radiotherapy, one, to target the residual or remaining tumor cells you couldn't remove during the surgery. So once you do that, you are reducing the risk of recurrence.
Okay.
With radiotherapy.
Okay. Before you move on there, Doc, the breast conservation surgery, can you explain what you're doing and what your objectives are with that?
So breast conservation, the aim is for to get a cosmetic effect or cosmesis,
Right.
to make sure that your nipple is intact, you don't have any deformity.
So
in your-
essentially, you are concerned about how the breasts look.
Exactly. That's
Right.
the aim of the surgery.
Okay. So you are removing cancerous cells
Yes.
with a view to protecting the look, right? The
Yes.
aesthetics, the cosmetics of
Yes.
the breast, which
Yes.
essentially is a gland anyway, folks. Okay, we know you are quite tied and fond of your breast, but essentially that's what it is. And Doc is saying with breast conservation surgery, we are going in to remove cancerous cells, but we're doing our best possible to safeguard and protect the shape and the appearance of the breast.
Yes.
Okay, I'm sure the women would love to hear this.
Yeah.
Right.
I mean,
So that's breast conservation surgery. You are still going in for cancerous cells. Now, the reason I'm hitting on this is that you said primarily you are aiming to preserve the nature, the look, the appearance, maybe even the feel of the breast whilst removing.
the tumor.
Right. And you said that objective is largely or primarily cosmetic.
Yes.
Okay. But you are doing something clinical or therapeutic in the sense of removing the cancer or the cancerous cells that have been identified.
Yeah.
Okay. Am I right in
Yes.
explaining it that way?
Yeah, you're right.
Okay.
So the cancerous cells, they form a mass,
Right.
a tumor.
Uh-huh.
That's the mass. So once you remove the tumor, and then we always say you need to get clear margins.
Okay.
So we give a margin of 1 to 2 cm.
Okay.
So once you remove the tumor,
Mhm.
the surrounding tissues, that's
Right.
1 to 2 cm surrounding the tumor,
Okay.
remove those healthy tissues.
So when you say margins, I've identified a lump. Let me use lump because it's more user friendly, but we're talking about a tumor or a cancer growth. When you remove it, right, what you're saying is that there are healthy cells around the tumor you've removed.
Yes.
Okay? And to be on the safe side, you give yourself a margin which you will still want to clear even though they are healthy.
Yes.
Because if there was any possible or potential spread, it would go
It's
in those
the
directions.
surroundings, yeah.
Okay. So when you say margin, you're actually creating a safe perimeter around where you took out the cancer or the tumor.
That's right.
All right. So when you say you want to have fine margins, what are you saying? Clear margins, sorry.
Or negative margins.
Okay.
So you want to have clear or negative margins. It means that after you remove the tumor with the healthy tissue, your assumption is that once they send the sample for histopathology,
Right.
it will come out with negative, with no tumor cells
In the
in
margin.
the healthy,
Right.
in the margins of the healthy tissues.
Right. Okay. So if you didn't have clarity on the margins, right, it means that there's a possibility that there may be some cancer cells in that margin. So what you're sharing with my listeners, and I'm trying to break it down, listeners, and pardon me if it sounds like I'm stopping Doc, but what it means is that when you remove a tumor, right,
Yes.
you want to be sure you've removed all of it. And then you also want to be sure the area surrounding the tumor you removed is also clear or clean of
Without cancer.
without cancer. Okay, so you send the sample, which means that in the tissue you removed in the normal perimeter, you will also send that for testing.
Exactly.
Wow, I've never understood it this way. So you send that for testing, and that would determine conclusively whether you have clear margins or not.
Yes.
Wow. Okay.
And then it will determine further management.
Right. If you don't have clear margins, what would be the next steps?
Means you need to go back to theater and
Okay.
then re-excise.
Right. You widen that margin.
Exactly.
Whoa. Which means more cutting.
Yes.
Wow. Okay. Right. He's smiling at me as he says it, but it's important we understand these things because you may hear some of these terms in discussion with your team, and it's important that you understand them. Let's check. I have this. Okay. Oye Inafenya welcomes me. Oye, salutes to you. Hi, Note. Please tell Doc to speak normal English. Some of us are getting lost. Right, we're breaking it down. Ernest and Abeka. Yep, that's what we do always. So we're slowing it down, right, so that you understand. Your questions are, welcome. So Ernest and Abeka, if there's something you didn't understand properly, do send a WhatsApp question, or soon when I activate the phone lines, you can ask the question yourself directly, okay? But we are trying to break it down, right? The lawyers also speak, in quotes, abnormal English. I'm sure Samson is doing his on the other side. But we do bear with us. Okay, so you take out that, and we were still locked down on breast conservation surgery, where you are doing all the things we've just discussed, but you want to do your best to keep the breast as it is. Right? And again, this underscores and hits on early detection and reporting so that we can catch it at a point where it is possible for you to do your conservation surgery, okay. Yeah. If it has moved and grown beyond certain dimensions or degrees, then of course it's more difficult to do that. Okay. No. Yeah. You also mentioned, Doc, that the location, right? I know what a breast looks like. Okay, I confess, I know what a breast feels like. But with regard to where it is in the breast, right? If it's at the lower or some will say under part of the breast, or the top or the side or near the armpit, are you suggesting to us that those present relatively different challenges for the surgeon?
Yes. So that will determine whether you are going to do neoadjuvant chemotherapy. Okay. So the neoadjuvant chemotherapy is just to shrink, to make the tumor smaller.
Okay.
And also, it's going to determine whether you are going to do mastectomy. Okay. This time, what people are always scared of, that's the mastectomy, removing the entire breast. Because with the mastectomy, you are removing the nipple areola, then the breast tissue with the mass.
Okay.
Yes, that's what mastectomy is.
Right.
So the location of the tumor, especially, we say that if the tumor, you have different tumors in different quadrants.
Okay.
So instead of just the right upper outer quadrant, now it's in the right upper inner quadrant. So you have two.
So you've taken the breast and you've divided it into 4 quarters, each of which you refer to as a quadrant.
Yes.
Okay, so it's like looking at the face of a clock and looking at the quarters, right?
Exactly.
So the surgeon is dealing with the breast in that kind of spatial, context, and therefore you're saying that you can have them in different quadrants.
Yes.
And that means what? Excisions or cutting in different areas of the same breast.
Yes.
Whoa.
But instead of doing breast conservation in this case, which will not be, we do mastectomy.
You would want to remove the whole breast.
Exactly.
And that is what you call mastectomy.
Yes.
Right. When you remove just the lump or localized lumps, is that what we call lumpectomy?
Yes, that's lumpectomy.
Right. So breast conservation is really lumpectomy with the shape and the look of the breast in mind.
Yes, but you see, these days, surgical interventions have evolved.
Okay.
So these days, we don't really do the lumpectomy.
Okay.
So instead of lumpectomy, we rather would want to say wide local excision, because now, apart from removing the lump itself, which is lumpectomy, now you are adding the margins or the borders of the tumor.
Right.
And then you add healthy tissues to it.
Okay.
That's the wide local excision.
Okay. Excision is to take out, right?
Remove, yeah.
To remove.
Cut out,
okay, so it's wide and it's still localized.
Yes.
Okay, I'm learning. So you can, I was going to apply it to fufu, but it's okay. I'm not going to go there. If you have any questions, concerns, 38 minutes past the hour of 2 on Joy 99.7 FM. We're looking at the range of surgical interventions. We have a general surgeon in the person of Dr. Charles Ansalabi. He's with the International Maritime Hospital, and we're going through some of these things, okay, and trying not to get too technical. One way of diluting the dose of technical terms is to announce and open the phone line. So 030-221-6541, 030-221-6541. You can ask the questions yourself via phone, and Doc will answer them. All right. We're still moving on. So mastectomy. That's where, based on the conditions we've discussed already,
yes,
you need to remove the whole breast.
Yes.
Okay. And I'm glad we're still talking breast and not plural breasts. Okay. How does removing, and sometimes we hear that both have been removed, right? In this case, we're sounding like we're talking about a case where the cancerous cells are localized in one breast. Okay. Let's talk a bit about the mastectomy, where you have to take away the whole breast.
Yes.
Right. My understanding is sometimes it's one, sometimes it's both. Okay. Let's start with one. So, on the basis of the spread and the clinical presentation, you may have to surgically remove the whole breast.
Yes.
Okay. Do margins come in here when you're taking the whole thing away?
Margins. So we look at, first of all, let me talk about the indications,
okay,
and
right,
then include the
indications
margin,
being the reasons or the criteria
why you would want to do mastectomy,
or the conditions under which you want to remove the whole breast.
Yes, because
okay,
people get scared when you talk about mastectomy.
Yeah.
Now people are afraid.
I'm just breaking down the use of the word indications. I know what it means, but indications means the criteria, the conditions under which you will remove the whole breast. Yes, Doc, continue.
Right. So instead of people getting scared, people shouldn't be scared again. Right. So first of all, we look at the tumor size. So if the tumor size is more than 4 cm, right, and then we come and look at the different quadrant.
All right.
I was going to say multifocality, but if the tumor is in different quadrants.
For every long big word, I'll give you a knock.
right. So you are going to look if it's in different quadrants. And then if it's a central tumor, if it's central, it means it's just around the nipple areolar complex area where your nipple.
Right.
Yeah. And then you look at the fact that the patient can benefit from radiotherapy or not.
Okay.
So in places where you can't have radiotherapy, instead of doing breast conservation, now you're going to remove the entire breast because you can't do radiotherapy.
Okay. Ideally, you'd want to follow up with the radiotherapy.
Yes.
Okay. Right.
You cannot. And then in pregnant women too, we don't do radiotherapy because of the radiation, which can affect the developing fetus.
Wow. Okay. So if a pregnant woman has breast cancer, right, that in itself
is an indication.
And also that in itself informs and determines the types of treatments she can undergo.
Yes.
Okay. Right. Yes, continue, Doc.
Right. So once you have your reasons, you've established your reasons, and then you've been to MD team, multidisciplinary team,
right,
where you have the oncologist, and then they've agreed that you can go ahead. Now, the next thing is whether you are going to offer neoadjuvant chemotherapy or not.
Right.
So the neoadjuvant chemotherapy is just to shrink the size of the tumor, so that when you remove the entire breast, you'll be able to close it.
Okay.
Right. Let me chip this in. So after you remove the entire breast, it's not the end of life.
Okay.
There are reconstructive surgeries you can do to have some kind of breast.
Right.
So that is, even though we talk about mastectomy, it's not the end of your breast. You can also get reconstructive surgery to have your something that looks like your breast.
Okay.
Right. Yeah. So after you do the neoadjuvant And then the next thing is to do the surgery, which will remove the nipple, areola, the skin, the breast tissue. And then you send it to the histopathologist, who will give you the pathological report concerning the surgery you did. Right? That's the mastectomy. Right? So if you have negative margins, where you talk about the negative margins, or you don't have lymph node positivity, then you don't really have to do follow-up like chemotherapy. You don't really need that. Yeah, so that will be based on the decision of the MDT, whether you need radiotherapy or chemotherapy. But for every breast conservation surgery, you need radiotherapy
to follow up. Right.
Yes.
Okay.
Yeah.
All right. But Doc, I'm going to announce the phone lines again, but I'm going to come back to you and ask, okay, so based on the findings, the clinical presentation and all that, you do a mastectomy. You take away the whole breast, right?
For just one side.
Right. After announcing the phone lines, what I would want you to be chewing on is, so can I say I'm cured? Is it gone? Right, you've removed everything. You've taken it away. Okay, whether I get a prosthesis or I get cosmetic, whatever, remodeling or something there, am I clear of cancer? Chew on that a second. Then let me just announce the phone lines, and I have a couple of WhatsApp to read as well. 030-221-6541. You can call us on Ultimate Health Joy 99.7 FM. 030-221-6541. If there's anything you didn't quite catch or understand when I was speaking to Doc. This one says, good afternoon. Is there any support for cancer patients? Because my mom, I suspect, is having one of her breasts becoming big. If there is, how do I get to them? Next week, I want to do something with some survivors and the support groups as well, okay? We've done the clinicians, the medics and all that, and we'll get to that as well. So there are several of them as well that will put their contacts and things out there, right? It's very, very important to have support group membership or participation in support group to help you, not just you, the person with the breast cancer or undergoing these procedures we're talking about, but even for family, right? It's very, very important. So this is somebody asking how to get a support group. Then she sends me pictures, I think they're not loading here, of her mom, right? Okay, thanks for sharing. Oh, okay. Doc, can you see? They should go to the hospital immediately. They need to go to the hospital. She doesn't. Does she tell us the age of her mom from the picture? There's no name. Abeku, mark this and I'll see if we can call. I can call her after and then see. But they should go to hospital. Thanks for sharing this. She sends pictures of her mom's breasts. Yeah, of course. There's clearly concern there. Okay. Right. Okay. So, Doc, when you take everything away, right? The object is to take away cancerous tumors. Okay. For a person with clear margins and so on and so forth, you're still saying mandatory follow-up with radio and possibly chemo, right? But can the person say that they are clear? Would they be told that you are clear of breast cancer?
Yes, so it's very important to have MDT meeting after surgery. I mean, we discuss everything. So
that's
we look at the
multidisciplinary team of oncologists, radiotherapists, surgeons, pharmacists, etc. Yeah.
So we understand that sometimes surgery can be curative. But in about 6% of patients, the 5-year recurrence, we have about 5% patients getting recurrence in 5 years.
Okay.
Right. So the reasons for the recurrence, sometimes you look at the tumor grade.
Okay.
If it's an aggressive tumor or not. You are looking at the age of the individual.
Okay.
You are looking at perineural, how the tumor has spread to the lymph nodes.
Okay.
Yeah, and then you are looking at the invasive nature of the tumor.
Okay.
Sometimes you consider the age of the individual too. For patients who are above 35, we know that the recurrence is there.
Okay.
So we look at all these things. Then that will tell you that there can be recurrence or not.
Okay.
But you can't really say that 100%
Right.
surgery is curative,
Okay.
because there can be recurrence.
Okay. So what we're doing essentially is management.
For some patients, they get the cure.
They get a cure
Yeah,
and they're clear of cancer.
they are cleared
Right.
of cancer.
But what you're saying is that that cure, if even it is achieved, is not solely or primarily on the basis of surgery alone.
Loan,
Right.
exactly.
Okay. Folks, phone line still active, 030-221-6541, 030-221-6541. We're having a very detailed discussion with General Surgeon Dr. Charles Ansah Labi of the International Maritime Hospital. As the last part of our treatment options and modalities, we've done chemotherapy. We hope you've understood that. We did radiotherapy last week, and today we're looking at surgery. Any questions, concerns, experiences, please feel free to share them. Right, so I don't have any new WhatsApps. So, okay. Where does... Yeah, go ahead.
Yeah, so let me talk about initially we were talking about just one breast.
Yes, that's where I was going.
So now let's go to the two breasts or both breasts.
Where both breasts are involved.
Yes.
And cancer has been determined and diagnosed in both.
Yes.
Whoa, okay.
So, yeah, there are cases where you can have cancer in both.
Okay.
Yeah. But in that case, we take it as advanced, as metastatic.
Okay.
If it's gone to the other breast,
Okay.
we assume that it's the same as going to the lungs.
Okay.
Because it's crossed. So
if it's both breasts, it has spread.
Yes.
Okay. It's not localized in one breast.
It's not localized, it's spread.
Okay.
But in cases where you do bilateral mastectomy, where you remove both breasts, so we are looking at prophylactic surgeries.
Okay.
So in the case of Angelina Jolie in 2013, where she had both breasts removed because of BRCA1 gene mutation.
Because she had the gene mutation. She opted.
Right.
So she said remove them. She hadn't developed cancer yet, and both breasts were removed.
Yes.
Right.
So you can have patients coming to you that even though I have cancer in one breast and then you remove the entire breast, remove the other one.
Remove both.
Yes.
Okay.
But it won't be on the same day.
Right.
Yeah. So after the surgery, the patient can
These are scenarios that do occur.
Yes, they occur.
And you can take that into consideration surgically.
Patient's consent.
And with patient's consent, you remove both breasts.
Yes.
Whoa.
Because they'll come to you that, I feel the tumor is back in the other breast. So doctor, please remove the other breast. So there are cases like that.
Even if it's not supported by your investigations, that there's nothing there, they want both removed, you will, with their consent, remove.
Right. Because they will say that, I feel there is something in it, even though you do your investigations and realize that there is nothing there.
Right.
But because of patient's consent, which we use as an indication for bilateral mastectomy, we take it out.
Okay, you take both away. Right. And again, when you take both away, there's still the follow-up with the other treatments.
Yes.
Okay. Right. How many... I don't know how to put it, but in terms of numbers, you must be looking at the numbers of breast cancer diagnosis we get annually. Then that must be quite a number of surgeries that have to be done.
Yes.
Of different types, be they conservation, be they total or wide area excision or whatever. That's quite a lot of surgical work.
Yeah, that's... So the downside in our community is the late presentation.
Right.
So by the time they come or they report, the tumor has spread to other vital organs.
Right.
So patients will then not benefit from surgery.
Right.
So that's the downside in our communities.
Right. Are there any complications or challenges that may ensue after surgery for patients?
Right, so complications are there with almost every surgical procedure.
Right.
So we look at the early complications and then the late complications. So with the early complications, you are looking at in theater, what happens?
Okay.
You know, during the breast removal,
Right.
sometimes you remove the lymph nodes. You go under the armpit because we know that it goes into the armpit. So you remove the lymph nodes there. So there is a big vessel there, the axillary vein, axillary artery.
Okay.
Right. Sometimes there can be an injury too.
Okay.
And then the lateral thoracic artery and then the internal mammary arteries.
Okay.
So they can bleed.
So you're worried
bleeding,
about possible damage to these vessels, blood vessels.
Yes.
Okay. Right. So these must be done by specialists then.
Yes. So
it's not just anybody going in there and snipping.
No, not just anybody.
Right.
I mean, once you are offered mastectomy, you should be rest assured that the person is an expert.
Okay.
If the person cannot do it, the person won't attempt.
Right.
Yeah. So we talk about bleeding as an early complication, and then there can be an injury to a particular nerve.
Okay.
Where your shoulder blade, that's the scapula.
Right.
It can push out. That's the winged scapula we talked about.
Okay.
Yeah, and then apart from the nerve, the blood vessels, sometimes you can have injury to, there's what we call intercostobrachial nerve. So with those ones, there will be numbness in the inner side of your upper arm.
So essentially, whilst you're going there targeting these cells and you want to remove them as best as you can, there are various systems, circulatory systems, nerve systems that you do not want to damage.
Yes.
Right. So these are what you are listing as possible negative or complications that may arise.
That's early complications.
Early complications.
Yeah, and then you can also have what we call flap necrosis, and then maybe surgical site infection.
Okay.
Yeah.
Right.
And apart from that too, when you are looking at the late complications, they have what we call lymphedema, and the entire limb will be swollen.
So your arm could swell.
Yes.
Right.
The upper limb.
So all of these are things that will be monitored should they occur, right?
Yes.
You're looking out for them to make sure that the patient is okay post-surgery.
Post-surgery.
Okay.
But even though I've listed these complications, the breast surgeries are being done by experts.
Right.
So we limit the extent of complications.
Okay.
However, some of them you cannot avoid them, especially with the lymphedema, because you are removing the lymph nodes.
Okay.
So once the lymph nodes are removed,
you may or you probably will experience some swelling of the arm.
Yeah, exactly.
Okay.
And then you are looking at recurrence. I mean, once you remove the tumor, you expect that there can be recurrence.
Right. You may get a regrowth or recurrence of cancerous cells.
Yes.
Right. So you're looking out for that. Doc, we're almost out of time. And let me ask you this. So how do I know I'm being handled by an expert or a competent specialist, right? I go into hospital. I'm already in distress, okay? You've mentioned things that I never thought I would associate with me, my life, my health, my body, right? So, yeah. You give me a date, and I'm despite my fears and anxieties, I'm looking forward to getting this done. But can I question who is doing what? Who is part of this? You know, it's very easy to say an MDT, multidisciplinary team, but how does the patient know? What are the safeguards for the patient?
So it depends on the hospital. So,
okay.
So the Ghana College of Physicians and Surgeons, they are training a lot of surgeons to be able to do these surgeries.
Right.
So you need to ask if the person is a surgeon.
Okay.
Yeah, that alone is okay.
So if they are qualified, that's good enough.
If they are qualified, that's good enough. Okay. And once the person is saying that I can do it, and then the person is a surgeon,
right,
you should be rest assured you'll be okay.
Okay.
And then you should go to a big hospital like IMA.
Does the size of the hospital change your outcomes?
It does.
When you say a big hospital,
not in terms of
not size,
big, yeah.
Number of departments, number of specialists, and so on and so forth. Right. Sure. Okay. Then you're bringing in big money too, right? Folks will bear with me. We haven't talked about the financial and other things. We'll do that when we do the support groups and the survivor stories, right? But so you're safer when you are in a facility that has the capacity and the range of specialists that are needed.
Yes,
right.
exactly.
Not that you're seeing one specialist here and then the anesthetist is somewhere else, and then the oncologist is not really there but comes there on Thursdays, and this one and that one. That's what Doc is suggesting. It's been an interesting journey. So we've looked at. Is there anything we've left out?
So that's the reconstructive surgery.
Reconstructive.
Yes.
Can we do that in a breath?
Yes, sure.
We have the minutes. Yeah.
Okay. So we have the early reconstruction.
Okay.
Where immediately after surgery, they can put an expander that looks like a prosthesis into the muscle. They'll bury it under the pectoralis muscle.
Right.
Yes. So then it's not a single procedure. It's a stage procedure. So they can do it about twice.
So we're literally rebuilding a breast for you.
Exactly.
We're putting something in there. We can build around it.
Yes.
Okay.
So there can be chances that based on the tumor grade and all that, that cannot be done in theater.
Okay.
So that will be the delayed reconstruction.
Okay.
So with the delayed reconstruction, it can happen in 6 months or 1 year after you've gone for radiotherapy and everything.
Right.
Then you can have another breast.
Okay. Right. So there's the possibility and the option of reconstructive